Stress, adaptation, and coping. And we're going to be looking at how this equates to anxiety. Part of all of what includes that feeling of anxiousness or anxiety comes from fear, or that feeling afraid or threatened by clearly definable outside external stimulus that makes that individual feel like this is a danger to them. With anxiety, though, it's a little bit different. That anxiety is a vague feeling of dread or apprehension, and it too is a response to external stimuli, but also that which happens internally. When it comes to anxiety, it is provoked by the unknown. It precedes all new experiences, emotions associated with the specific object. It's communicated interpersonally. It is the crux of an individual's self-preservation. And as mentioned, there's that feeling of uncertainty, helplessness, isolation, alienation, and insecurities. Now, a normal anxiety response is appropriate to the situation. In normal anxiety, it can be dealt with repression. You can kind of hold it back. It's used to help identify what underlying problems cause the anxiety. If you want to mark this slide, you need to understand that anxiety is a response to stress. So when we're dealing with our patients, if our patient says that they feel like they're more anxious than they normally are, then we have to ask them what additional stress or stressors are they experiencing. So stress is that wear and tear caused on our body by life. It occurs when someone has a difficulty with dealing with life situations, problems, and goals. And each person, remember, I handle stress differently. So each person experience is going to be different from the other. Some examples that may cause stress include public speaking, teaching, marriage, children, getting on an airplane, dogs, new jobs, schools, leaving at home. And with anxiety disorder, it's important to understand that this is a very common psychiatric disorder that affects 15 to 25% of the population. But important, of that small 15 to 25%, only 25% of these individuals receive treatment. And so as a result, you have a higher number of individuals using healthcare facilities with complaints of chest pain, shortness of breath, palpitation, only to find out that they're actually having anxiety. With GAD, or general adaptation syndrome, there's an alarm reaction. So stress stimulates the body to send messages to the hypothalamus that then send out messages to the gland and other organs to prepare it to be ready to be in defense. In the resistance stage, the digestive system slows down, the lungs start to take in more air, the heart begins to beat faster and harder. And if the person is able to adapt, then their body relaxes. If they're not, then that's where you'll start to see maladaptive responses occur. In the exhaustion stage, there's a negative response to stress. The body stores are depleted, and as a result, there's some these emotional components causing the anxiety. They're not resolved. Now, with that sympathetic response, our body begins to activate, and that's that fight or flight. So the cortex of the brain sends out messages to the autonomic nervous system. The adrenal glands begin to get that epinephrine ready, and so individuals, as they begin to respond, their O2 goes up, their heart rate goes up, their blood pressure may go up, and so because of all that shifting of blood in order to take care of the fight or flight, there's not enough going to the GI system, and so therefore the stomach and the intestines, those things begin to slow down. Um, you may even begin to see changes in the blood glucose level. Um, and so all of these things are beginning to erupt, and so when it comes to general adaptation syndrome, you'll start to see that there's an emotional, physical response that can be seen through vital signs and changes within the individual. Bodies normally respond to it, usually relaxes, everything goes back to normal, but when it doesn't, they get into that exhaustion stage, and then things start to go awry, and that's when it becomes maladaptive. So theories of anxiety includes the psychodynamic and Freud, who says that person's innate anxiety stimulates their behavior, and their defense mechanism is an attempt to control their awareness and reduce anxiety, and it's that conflict between their id and their superego. With Harry Stack Sullivan, it's all about interpersonal. It's this, it's the anxiety that's generated from problems that it can exist within interpersonal relationships. With Skinner, there was the idea that anxiety was based on earlier experiences, but through trained therapists and some cognitive behavioral therapy, these behaviors can be extinguished or unlearned through repetition, repeated exposure. With Hans Sales, I'm not sure if I'm pronouncing that right, you will not be tested on this, but he was the one that had a theory on general adaptation syndrome that basically um, led some of the additional theories that we have with Freud, Sullivan, and Skinner. Um, and with genetics, there's some information that basically says that there's some familial attachment to why people have anxiety genetically. It is important that you understand and read the notes on these anxiety levels. Understand that mild is something that gets our attention. It's that good anxiety in which people are motivated to change and learn. We as students, or you as students, use this to study for exams. It prepares you for action. It heightens all your senses. Mild is really good. That's the adaptive portion. We handle that better. With moderate, we begin to feel like something's wrong, and so as a result, we begin to build up some nervousness, agitation. Um, it's processing information and problem solving. It becomes difficult, especially because of our concentration. With severe, the our perception starts to be reduced. The behavior is directed at trying to relieve the anxiety. However, muscles begin to tighten, vital signs begin to increase, and as a result, neurosis and severe psychiatric disturbances happen here. And so at this level of severe anxiety, there's trouble thinking and reasoning. And with panic, they can't process what's happening in reality. They lose contact with reality, and they're definitely in psychosis at this point. They're dysfunctional in their coping mechanisms. And so because of this, these individuals, you're severe and you're panicked, you have to be concerned about keeping them calm, like keeping the environment calm, decreasing your stimuli, and then being careful because these individuals are at risk to a harm for themselves and others. In order to relieve the body of all that anxiety, there's a portion of an individual that acts out behaviors in order to bring about calm. Unfortunately, this behavior is maladaptive, so it can include anger, and that can be used to conceal what that individual is really thinking, or feelings that may trigger anxiety. They may cry, because it's soothing. They may laugh. And just remember, with laughter, that doesn't release endorphins, and so therefore there's a relief of tension. And others, there is physical and verbal abuse to distract from the threatening realization that is happening. Other times there's somaticizing. It's actually physical symptoms in the absence of there being anything clinically wrong. And so these things can happen sometimes around the age of 30, where you'll start to see individuals come in. Different types of somaticizing, including SSD, which is somatic symptom disorders, and that again is the manifestation of psychological distress or physical problems without a clinical significance to it. Then there's complex somatic symptom disorder. Your DSM-5 will sometimes show that these individuals will have complaints of GI or neurological backaches or musculoskeletal leg pain, sexual issues, and these things can last on from 6 to 9 months. When it becomes complex, they seek help from multiple providers, but they avoid any mental health professionals. Other learning behavior for relief is learning how to problem solve. When anxiety is recognized and the unconscious unmet need is identified. So adaptively, if someone is doing really good, they can understand, hey, this is causing me anxiety. I know what it is. Okay, now that I know what it is, I can identify what I need to do, and therefore the body begins to decrease in the stress. The ego defense mechanism is a cognitive distortion that's done unconsciously. People don't know that they're doing it. They use it to maintain a sense of being in control. It decreases their discomfort, and it helps them deal with stress. Again, they're unaware that they're doing it, but it also inhibits emotional growth. It results in poor problem solving, and it can make it difficult for these individuals to have healthy relationships. With nursing diagnosis in relation to anxiety, one, there's the collection of assessment data. They have to decrease their attention span. They're going to have restlessness and irritability, poor impulse control, and panic anxiety. And I'm going to go back. They're going to have a decrease in their attention span because of that anxiety. They're not going to be able to discriminate harmful situations. They're going to have disorganized thought processes and delusions. And as a result, this is what makes us have to be cautious with these patients. We got to be thinking about what's causing their additional stress. Some nursing diagnoses that you might see include ineffective coping, which is really the main problem, the readiness for enhanced coping, safety related to suicide tendencies. That suicidal tendency is related to the fact that one, they have a decreased attention span. They cannot discriminate harmful situations that put them at risk. They have disorganized thoughts, and they can have delusions that can create harmful situations for them. They can have feelings of discomfort, apprehension, helplessness, hyperactivity, pacing, the wringing of their hands, their perceptual fields. They have deficits with those, and they have decreased abilities to be able to communicate verbally. So, what are we thinking about when it comes to our outcomes? The expected outcome is that the patient will demonstrate adaptive ways of coping with stress, and that the patient will identify triggers. For a severe panic level, we're going to address the patient's safety, address anxiety levels. We're going to evaluate for decreased anxiety and positive behavior. And the goal is to not be free totally from anxiety. That's not going to happen. But in the planning process, we can help the patient to develop the ability to tolerate mild anxiety and to use it cautiously and constructively, to be stronger and to actively participate in their treatment plan by identifying stressors and triggers and then planning the solution. In their immediate, again, they're going to be free of injury because we're thinking about safety. So we're going to get them to start talking about those feelings that they have of anxiety, and then help them to develop some relaxation techniques. In the stabilization phase, we're helping the patient to demonstrate those ability to use those relaxation techniques. And then when we think about community goals, the client is going to be able to be free, or have limited anxiety attacks. They can have anxiety, but maybe free from anxiety attacks, and then help them manage their response to stress effectively. In the implementation phase, we're going to make sure that the patient remains, we're going to make sure that we're with the patient at all times, especially during that severe and panic, because they can present as a harm to themselves. We're going to maintain a trusting and open relationship in a calm environment, decrease their stimuli of the environment. Do not force them to make choices related to decision making, because that capability is decreased. So we got to make sure we're using short, simple, clear sentences, help them to problem solve, tell them what they need to be doing. Avoid forcing them again to make choices, and then using PRN medications like Ativan and Klonopin to assist them. With anxiety disorder, this is when the patient has prolonged exposure to anxiety. They've now passed the phase. They're at this point where there is psychological and physical problems that have arisen. Their behavior becomes maladaptive. So anxiety is going to be the major role in this person's life, and it's going to be chronic for them. In addition to the maladaptive behavior, they're going to have emotional disabilities. With anxiety disorder, it's going to be one of the most common ones that you will see amongst patients in the hospital. And it causes them considerable distress, and they do have impairments to their functionality. With comorbidities, a lot of times with anxiety goes depression. Your DSM-5 talks about mixed anxiety with depression. They can have dysphoric mood plus 4 of any of these for 1 month or more. So they can have difficulty concentrating, sleep disturbance, fatigue, irritability, worry, hypervigilance, always anticipating the worst, and having low self-esteem. Remember, with depression, this is more severe, and sometimes it can have a poor prognosis with our patients who have anxiety disorder. There are some theories that look at biological, traumatic, genetics, and cultural variances that can affect anxiety. Other types of anxiety disorders include panic disorders. That's usually described as an attack followed by symptoms over a month period, where they can be concerned about attacks, worry about consequences, can have significant change in their behavior, and they may or may not have some agoraphobia with that. And agoraphobia is a fear of outdoors. With panic disorder, it's an intense fear of discomfort. Signs and symptoms include palpitation, pounding heart rate. They can be sweaty, trembling or shaking, shortness of breath. A lot of the times medications used to treat this will be SSRIs or cognitive behavioral therapy with a therapist. Usually as nurses, we are the first ones to discover our patients, and that's on a med-surg unit. So this is even before they get to psych. Other biological findings include the fact that with GABA, and then with their norepinephrine, it can be too high, or their GABA can be low, and as a result, it results in that individual going into a panic attack. We talk about phobias, and I talked about agoraphobia being that intense feeling of like spaces or situation, more so sometimes being outdoors. Um, there's fear. That increase in anxiety leads to fear, and so therefore they avoid the spaces. They rather be alone. They have difficulty traveling in the car or the plane, being on bridges and elevators, and so this need to avoid this behavior can become debilitating. With social phobias, individuals have social anxiety disorder, so they have a fear of speaking in public. So they act in a way, they're afraid because that they'll act in a way that's embarrassing. Some biological theory says that there's a surge of epinephrine that causes that social anxiety in relation to interacting with others. And so therefore we need to be teaching them social skills that include relaxation, exposure to what is giving them fear, get them frequently engaging in public speaking, or get them going outdoors. And after they begin to decrease that fear, and begin to have that safety, then their anxiety will go down and they're more apt to, want to engage. And then sometimes you have to use medications, including SSRIs. Obsessive compulsive disorder has two components. You have your obsession, that's recurring persistent thoughts, impulses, or images expressed in inappropriate ways. With compulsion, it's a repetitive behavior that person is compelled to perform in response to the obsession. So hand washing and checking appliances. It's really important to understand the difference between the compulsion. If they don't want to do it, like washing their hands, but that com- compelling portion makes them have to do it, or they will have anxiety, and the anxiety won't go away until they actually perform the behavior. There's some biological evidence that shows that obsessive compulsive disorder can be caused by deficits in uh, serotonin. So what do? One, we can use behavioral therapy to give them exposure. We can use response prevention. Sometimes medication, Luvox, Zoloft affects her. For the patient, remember again, compulsions are necessary, not pleasurable, but it reduces their anxiety. Patients will need cognitive behavior therapy and SSRIs. And this biological response, that serotonin, that's usually um, seen in their frontal lobe. With generalized anxiety disorder, this is something that happens again for 6 months or longer. They have to have 3 symptoms present. There's a biological response that says that it might be neurochemicals or some type of physical condition that can cause GAD. Their worry becomes out of proportion to events. It affects their interpersonal relationships, their jobs, and their finances, and their family unit is affected by it. Treatment, we encourage relaxation, exercise, and CBT. The goal is to bring that worry process under the person's control. If they can get that worry under control, that will decrease anxiety. However, at times we have to use medications like buspirone and Effexor. Signs and symptoms that will include restlessness, fatigue, sleep disturbance, sleep disorder, poor concentration, irritability, tension. And they may even have shortness of breath or dizziness. Now, post-traumatic stress disorder is a traumatic event that happens to a patient that's beyond their control. With these events, these individuals will report having flashbacks. The diagnosis is looking at the actual traumatic event. That person's going to have intense feelings of fear, helplessness, and horror. They're going to be re-experiencing the event. That's some flashbacks, thoughts, and images. They're going to feel real to them. They're actually going to be not only experiencing psychological distress, but they're also going to be having physiological responses. They're going to try to avoid really not only things that might trigger that event, but a lot of times they'll start avoiding people and become isolated in a way to decrease the anxiety or to numb these thoughts and feelings that they may be having. Sometimes it will be conversations. Symptoms of hyperarousal are not present before trauma. There's some biological findings that says that there's a part of their brain that's damaged. In respects to norepinephrine. Some examples of PTSD can be shell shock, combat fatigue, PTSD from Vietnam War. These individuals are going to be treated with SSRIs, and the focus is going to be on getting them through the present and helping them develop coping skills. And a lot of the times, they're going to need outpatient therapy. So some assessment guidelines. We're going to be using sound physical and neurological examinations, assessing them to make sure that they're not a harm to themselves, using psychosocial assessments, assessing them for suicidal ideations, again, if they are harm to themselves or if they're passive or active in those thoughts, and then making sure that we're being culturally competent to be able to give them the best plan of care. Next, we're going to be looking at nursing diagnosis, which include fear, anxiety, ineffective coping, ineffective role performance, impaired verbal communication, disturbed thought processes, and disturbed sleep patterns. Our outcomes and goals will be that the client will demonstrate absence of physical symptoms. They'll identify indicators of their own anxiety, that the client will verbalize feelings of anxiety appropriately, and that they'll demonstrate use of new coping skills. If their coping skills are poor, then these individuals might resort to self-medicating, and that includes alcohol or other substance abuse. With planning and intervention, we need to be thinking about identifying community resources, support groups. We have to include their family and significant others, medication, education, cognitive restructuring, cognitive behavior therapy, relaxation training, modeling, and systematic desensitization. Medications include benzodiazepines like Klonopin, Xanax, Ativan, SSRIs, and tricyclics. In order to promote effective coping, we're going to have to treat them, whether it be PTSD or whether or not it be rape. We have to deal with their fear and their rage, especially to the family member or the abuser. Remember that as a nurse, part of your treatment team, especially in the ED, is to provide emotional support, not to rush through our examination procedure, give control to the patient as to who they're going to call and when. That's the way we're going to give them control back into their hand, because in that moment something's been taken away from them. We have to figure a way how to get that back. We have to use proper procedures within the ED, including your SANE nurse, which you may have to give them phone numbers, rape counselor appointments, making sure though that before we do anything else, physiological needs are taken care of before psychological. No, nothing that we do psychologically is going to be good to the patient if they're not alive for it. Then after they've gotten the physiological treatments, and then they're open to, we've established that client nurse-client relationship, only then can we start promoting effective coping, and then giving them that support that they need psychologically.